Good morning. We're going to talk about pain management and labor for a little bit. Realize that everybody has pain in labor. Pain is universal. It's a universal experience whether we're in labor or not. But how people respond to that is going to be highly individualized. Large studies have been done. There's been 16 trials. What they found out is women who are supported in labor have slightly shorter labors. Now, what is slightly and is slightly worth it? Again, I want to remind you, I've never had any woman tell me when this is all over, "Oops, I wish this would have lasted just a little bit longer." When they're really supported, when they have one-to-one interpartum support, they're more likely to have a spontaneous vaginal delivery, meaning that we're not using forceps or vacuum extractors to help deliver this baby, less likely to have interpartum analgesia, and less likely to report dissatisfaction with the experience. If you remember from one of our previous discussions, when the patient feels supported, when they feel like they're part of all the decisions that are being made, they tend to be much more satisfied with the birth experience. And this is regardless of the birth outcome. Women who have had healthy babies with APGARs of 10 and 10, meaning a perfect baby, can be highly dissatisfied with their labor experience because of the experience, because of how the nurse made them feel, because of how the provider made them feel, because they weren't part of this. Conversely, women who have had babies that did not survive labor have still reported great satisfaction with the experience because of how well they were treated by their labor nurses, by their providers. They were made a part of all the decisions for this whole process. Author's conclusion: all women should have support throughout labor and birth. That's basically what I've been saying since we started talking about labor and delivery. Continuous labor support is a non-pharmacologic pain method that we can employ at the bedside. And continuous labor support does not mean that you're in that room 24/7. It means that you're in there frequently. It means you're in there taking care of the patient, not the machine. It means you're supporting her decisions. It means you're encouraging her to get through this process. Who is that continuous labor support person? One is you as the nurse. Two, it's who do they want in their room as their labor coach? And it's not up to us to decide who that should be. This should be the mom's decision, the family's decision. Remember, some cultures, it's very specific who that person is. Some cultures, it's not the father. It's the grandmother of the baby. Either mom's mom or dad's mom is the one that's supposed to be in there helping this mom become a mother. Allow her to assume her own position of comfort. And I frequently hear, well, you need to stay in this position because this is the best position to be able to hear the baby. Our job is to find that baby and keep the baby on the monitor. It is not the mom's job to make that easy for us. We need to let her get in the position she's most comfortable in, get the baby on the monitor, and then to encourage her to change position, even if that means it takes us a while to chase that baby and get that baby back on the monitor. We're not doing her any favors by keeping the baby on the monitor if we're not helping her progress through labor. Perception of pain, very cultural. We talked about that in an earlier session. Either very vocal or very stoic. Please don't let your response be based on their volume. Our moms who have a history of abuse, especially sexual abuse, may have a heightened reaction to the things that we're doing while she's in labor. Things like our vaginal exam. She's crawling off the other end of the bed, and it's like, I haven't hardly even touched you. That should make us concerned that there's a history of sexual abuse here. Sometimes substance abuse. They're not responding to the pain medications in the same way because of their history of substance abuse. Other stimuli in the environment. It's not up to us what kind of stimulation they have in the environment. This needs to be their environment. And if that means that they're listening to country music, great. If that means they're listening to classic music, great. rock and roll. I can't tell you how many times in labor I have gone in and out of the room and they're watching Jerry Springer where they're throwing chairs, cussing each other out, trying to decide if that guy is the baby's dad. While it wouldn't be my choice while I was in labor, it happens so frequently, it must be a really good thing to watch while you're in labor. A lot of times, if they're coming in to be induced, when I would teach childbirth ed classes, I would tell them, bring in something to distract you. Play games on your cell phone. Bring in cards, bring in backgammon, bring in something to distract you because if you play this game for 30 minutes, an hour, and it's distracted you, that's 30 minutes or an hour closer to delivery where they've done something and occupied their mind in a way other than waiting for that next contraction. Anxiety and fear increases their perception of pain. This is another reason I really believe in childbirth education. Not so that I can convince them that they have to breathe and so they don't get their epidural, because that was never my belief. My belief is do what you want to do and what you need to do to make this your birth experience. But we talked about how anxiety increases your pain because you're all tense and you're all drawn up. If she doesn't know when to come to the hospital, if she doesn't know what to expect coming next, if she doesn't have an idea of what's going to happen or what's going on currently, it increases her anxiety, increases her fear, therefore increases pain perception. We do know that the anxiety and fear decreases the effectiveness of her contractions. Therefore, she's going to be in labor longer. So let's teach her how to deal with what's going on now and what to expect. Previous experience. She remembers when she had a broken leg and how miserable that pain was, and oh my gosh, she just can't deal with that kind of pain again. Childbirth pain is a different kind of pain. Childbirth pain, and sometimes we say that for a first time mom, they're going to be in labor for about 24 hours. And these women, they just get so scared thinking that they're going to have this incredibly intense pain for the entire 24 hours without relief. And that is not true. Remember, we've talked about that latent phase. That latent phase can last for hours where they have occasional contractions. They're not very regular. They're not very strong. Yeah, I had another contraction. Okay, I'm done. Sometimes they sleep through this. Sometimes they work through this. So help them to understand that this is not a 24 hours worth of nonstop pain. That goes along with helping her know what's going to happen next, which will help with this anxiety and fear, support and comfort. Please don't underestimate the power of your support and comfort at the bedside. Sometimes our coaches at the bedside have no idea what to do either. And so we have to help support them as well. And then what is that environment? If mom is exhausted, then we need to make sure that her environment is calm and cool and she can get some rest, doze between contractions, or maybe even sleep between contractions. And if that's what she needs, then we need to help control her environment. Asking her, would you like everybody to leave? Or by encouraging everybody else in the room to please be quiet and let mom get some rest. They feel like they're in there and it's a party. And while that might be good early in labor to help keep her distracted, might not be good later in labor when she needs to be resting between contractions. It's not up to us to tell her who she needs in her room. Years ago, it was only dad. Well, when I was delivered, my mom delivered by herself, her and her doctor. My dad stayed in the waiting room. That's the way we did things. Then we started allowing only dad, and we wouldn't let anybody else in the room while mom was in labor because we felt like that was what was most important. But I'm her mother. Well, it's only the dad. Or you can come in for 5 minutes and then you have to leave. There's no reason we need to limit the people in the room. Who are we to say who her support people needs to be? Yes, she very much wants her spouse in there. Yes, she very much wants her mother or her sister or her mother-in-law or her best friend. It's up to her to decide who she needs in there. Making a difference as part of the labor support team. Our non-pharmacologic efforts to help her control pain Hydrotherapy. When we have telemetry, and then we do have fetal monitoring telemetry, we can let her get in a whirlpool. And some of our hospitals have whirlpools that they'll allow mom to get in while she's in labor. Or just getting in the shower. If she gets in the shower 10, 20, 30 minutes, that's 10, 20, 30 minutes down the road, further into labor, closer to delivery. And if that provides comfort, let her go for it. Acupressure, certain places on mom's body that she can push to help, one, stimulate some contractions, or two, increase serotonins to help her body deal with this even better. Aromatherapy. Sometimes things that make us remember, some smells that make us remember things from the past can be very comforting. Hypnosis. I've worked with some of our anesthesiologists that works with hypnosis for decreasing dental pain during dental procedures and expanding that into other areas of pain control. And there is some research out there about hypnosis during labor to help decrease labor pain. Is hypnosis going to make it completely go away? Probably not. Is it going to make some of it more tolerable? Yes, probably it will. When I first started in OB, we didn't have epidurals. It was very rare that somebody got epidurals, so they got a lot of IV pain medications. And a lot of them went to childbirth ed classes, and they did use their breathing to help with labor pain, up walking around since they didn't have their epidural, things to help stimulate the contractions, to help them move through this process faster. And I saw those women come back for a second baby, even without an epidural. So some of these non-pharmacologic measures can be highly effective. But our mom has to believe that they will in order for them to be effective. So hydrotherapy, this bottom picture down here, this is telemetry. Please do not put your mom in a tub if she is connected to something that is plugged into the wall. That would not be a good outcome. We have stimulation, counter pressures. We talked earlier about when mom has a lot of back labor. Sometimes when mom has a lot of back pressure, if somebody can put pressure with the heel of their hand on mom's lower back, it helps relieve some of that discomfort from that back labor. Efforage, that's where we see moms doing this all the time, where they rub their belly, maybe in circles, maybe up the center and down around the sides and back up the center. Stimulation helps increase comfort. Touch and massage, heat and cold. And heat and cold can be very effective, but we have to be very careful because if we're talking about heat, what are we talking about? A lot of times we talk about warm packs. So how do we make them warm? A microwave. Well, we're not going to be allowed to use the unit's microwave in order to warm those up. Some hospitals have microwaves in each patient's room so that they can warm up warm packs. Ice packs, maybe on mom's back when she's having some of that back labor, but certainly ice packs on her bottom after delivery. We talked about water therapy, just having the water run over her or the sensation of the whirlpool. That's a sensation kind of relaxation. And then the TENS unit. Picture of the TENS unit. This provides low electrical stimulation, and this overrides the pain pathways, so they have this sensation of a little tingle. Should not be a shock, but a little tingle for this overrides those deeper pathways of the labor contraction. This is where you would provide counter pressure in the point of back labor for mom. And again, you want to use the heels of your hands, not your fists, because your knuckles are too hard and can increase the pain. Other non-pharmacologic pain control methods are breathing techniques. Never underestimate the power of position changes for comfort and to help labor progress. Movement, getting mom up, walking, rocking, out of flat on her back in the bed. Emotional support and encouragement, like we said earlier. Breathing through contractions. Positive reinforcement and continuous updates on her progress. Make sure that you are nursing the patient, not the machine. Remind them that labor takes time. It took her 9 months to get to this point, There's a reason it takes so long. The muscles at her pelvic floor, that cervix, those are all built to hold this baby in this uterus. And so it's going to take time to help make that relax and move out of the way to allow this baby to deliver. We don't want it to happen immediately. If it does, it doesn't gently stretch those muscles to get them out of the way. If it happened, boom, then we have a lot of tissue damage because it happened so quickly. Pain medications are opioids. We want to try to give it less than an hour prior to delivery, which means it hasn't really had time to circulate and get to the baby, or greater than 4 hours prior to delivery. And that way, what has gotten to baby has been metabolized, and they're not going to have such effects once they're born. I'm here to tell you there's no way to know when an hour prior or greater than 4 hours from delivery is going to be. We can use our best guesstimate based on what's going on. The advantages are that it provides relaxation and analgesia. It counters the effects of those catecholamines that we talked about, so it enhances the process of labor, it enhances the contractions. It's low cost and can be given by the bedside nurse. Mom can typically still move and assume different positions, can still get up and ambulate to help her own labor progress faster. The disadvantages are that it's not complete pain relief. Mom is still going to feel her contractions. Her contractions may still be very uncomfortable. They might slow labor down just a little bit. May cause hypotension if it's given too fast. And if we cause hypotension in mom, we're going to decrease the perfusion through the placenta and have effects in our baby. Parenteral medications do circulate through that placenta and do get delivered to our baby. That's why we want less than an hour before delivery or hopefully greater than 4 hours. And it can result in respiratory suppression in our newborns. If that happens, we're going to give Narcan. And we give Narcan to counteract the respiratory suppression in our babies, not our moms. Our moms typically don't have respiratory depression because of getting IV meds. Or we can use Narcan to counter the effects of our epidural medications. And some of the epidural medications cause pruritus, just intense, uncomfortable, unrelenting itching, nausea and vomiting, or urinary retention. So we can give Narcan to counter those side effects. We have nerve block anesthesia and analgesia. We have local anesthesia where we're actually only numbing the perineum. We can do a pudendal block, although this is less and less common because of epidurals and spinals becoming more and more common. And the pudendal block is numbing almost all of the perineum. The pudendal, or the spinal anesthesia, that is our epidural, our spinal, or a combined epidural and a spinal. And the difference between the epidural and the spinal is where exactly are they putting that medication. Our local anesthesia, our local blocks, or our regional blocks, we're using local anesthesia, and it's used just to numb the perineal tissue, either for the episiotomy at delivery or for the repair of the episiotomy or perineal laceration. Pudendal, injected into the pudendal nerves a couple minutes before delivery, and it numbs almost the entire perineum. Then we have the epidural and the spinal that we talk about. Before we give an epidural or a spinal, we always have to give a bolus of fluid, and we have to know what her platelets are prior to giving this epidural. So she walks in the door, she wants her epidural. The minute she walks in the door, she can't have her epidural until we get a CBC and get a platelet result back. Why do you think that is? We want to know what her platelets are before we stick a needle in through her spinal cord and around her spinal covering. If she has a clotting problem, we want to know that before we puncture that epidural space. Because if she can't clot off, then she's going to bleed into that epidural space and it can compromise our cord. We always want to have an IV so that we can give a bolus of IV fluid before we give this epidural. And our bolus of IV fluid is typically going to be 500 to 1,000 mLs of fluid. We just open it up and put it in. Now, for med-surg purists, that makes you have a stroke because, oh my gosh, that's a lot of fluid. And yes, it is a lot of fluid. But remember, we're talking about normal, healthy women most of the time. They are vasodilated because of the pregnancy. When we give the epidural, one of the side effects of an epidural is it causes increased vasodilation in the periphery. That can significantly drop mom's blood pressure, which is going to affect perfusion through the placenta, which is going to affect our baby. How do we prevent that? We prevent that by giving her a bolus of fluid. When she gets her epidural, we're doing vital signs every 5 minutes during this. And if we notice a drop in her blood pressure, greater than about a 10% drop in her blood pressure, first thing we're going to do is rebolus her with another 250 or 500. If her pressures continue to remain down and affect the perfusion through the placenta, then we typically have to call anesthesia back. If they have already left the room, we need to call them back. And they're going to give mom a medication called ephedrine, which causes vasoconstriction so that we can get mom's blood pressure up so that we're perfusing the placenta. Our laboring epidurals typically give pain relief up to mom's umbilicus. A surgical epidural typically gives pain relief up to about the nipple line. We have what's called an intrathecal, and what that is it's like an epidural, but instead of leaving the catheter in there where mom would get continuous bolus of medication, this is a one-time bolus. We remove everything, and we do this because we anticipate mom is probably going to be delivered within about 4 hours. This would provide adequate pain relief throughout the remainder of her labor. Our job is to make sure we have our labs back, make sure we have an IV, an effective IV in place and that we've given the bolus, and then to help position mom and to do the vital signs while this epidural is being placed. So we have them roll up in a ball like this. This would be how we would have her roll up into a ball if she came in for a C-section. We took her to the OR. We did the epidural in the OR. If we're doing the epidural in the labor room, we typically have her lean across her bedside table, arch her back like a cat, and when she's arching and pushing her back outward, it separates the spinous processes on the spine so that we can actually get a needle in between those bony prominences on the vertebrae into the spinal cord to inject medication. Once it's done, it's all taped off. This is the epidural catheter that comes up on her back. It's all taped off. There are no ports on an epidural tubing, and that's so nothing else can accidentally get injected into this epidural. One of the complications from an epidural or a spinal is that they get spinal headaches. It's a post-dural puncture headache, meaning that there's been a puncture and it has allowed some of the cerebral spinal fluid to leak out. And when that happens, the pressure in the brain from loss of the cerebral spinal fluid causes this headache. We're not going to see this in the immediate post-epidural time frame. We're probably not going to see this on labor and delivery. It's probably going to be days later. What do we do about this? We do what we call an epidural blood patch. We take some of mom's blood from her arm, turn around, and inject it into her back. And we put it in that epidural space. And because it's a blood patch, there's clotting mechanisms in that. It's going to seal off where that leak was. Mom has to lay flat for about 24 hours after this so that that spot can heal and clot off so she's not leaking spinal fluid anymore. We have our regional blocks such as our spinal or a combined epidural and spinal. It's local anesthesia, sometimes combined with a narcotic, injected in the subdural space through a needle for anesthesia for OB surgery. Combined spinal and epidural. It's an epidural needle inserted, then a smaller spinal needle is inserted through that into the subarachnoid space. When we're doing this one, we don't use local anesthesia. Advantages: frequently provides complete pain relief. A disadvantage is it may not provide complete pain relief. And sometimes our moms can still feel their contractions, or there's one spot or the other that's not numb at all. It's extremely uncomfortable, and she wants to be sensation free. And I always remind our moms that this is not sensation free. You might still feel your contractions, but you're not going to feel the pain of them, so you don't really care about them. They tend to be very disappointed if they think it's going to be sensation free. And they'll complain and say, I can still feel my contractions. Okay, on a level of 1 to 10, what are they? They're about a 2. Okay, that's hopefully tolerable. We may not be able to get it any better than that. Pain medication is given continuously, or it can be bolused. They can also have an epidural PCA where mom controls when she gets her meds. Those medications don't directly affect the fetus. Remember I said that the epidural can cause a vasodilation in mom, a drop in mom's blood pressure, prevents perfusion through the placenta. So obviously that's going to affect the fetus, but the meds themselves, the epidural themselves, don't affect the fetus. And our epidurals and our spinal can be used to provide surgical anesthesia. Disadvantages: it is more costly than a narcotic via IV. It does require an anesthesia practitioner. It is invasive, so it carries the risk of infection and bleeding. Limits mom's mobility, so mom can't independently change her position a lot of times. She can't get up and walk, so gravity can't help her. Slows first and second stage labor. And this has an exclamation point and a question mark. It honestly depends on what research you read. Sometimes if this is given too early, before mom is in effective labor, it can slow down those contractions. Sometimes it can slow down second stage. We talked earlier about sometimes we have to let some of this anesthesia wear off so mom can feel her contractions so she can effectively push. If that happens, that's going to prolong second stage labor. Because of that, there is an increased rate of operative abdominal and vaginal delivery. So what does that mean? It means it can increase the risk of a C-section because she does not continuously progress in her labor, or if she's pushing and she's not effectively pushing, or she's completely exhausted or can't feel her contractions, then it might result in either having to use a vacuum extractor or forceps, which are operative vaginal deliveries. It can also increase the use of our Pitocin. We talked about one of the complications being the maternal hypotension. Remember what we do to prevent that. Can cause a spinal headache. What are we going to look for and when are we going to see it? What do we do about it? We can have total spinal block as a complication. And what that means is that anesthesia has risen. Those meds have risen so high that now she can't even breathe on her own. General anesthesia, the absence of sensation and consciousness induced by various anesthetic gases or agents, not necessarily gases. It can be inhalation or it can be an injection. This is only used for true emergency deliveries. In those cases where she does not already have an epidural or a spinal, and we need to get that baby out in the next few minutes, then we're going to use general anesthesia. Even our urgent requirements for delivery, we can dose up an epidural and make it a surgical epidural so that she has good pain relief for an operative delivery. The advantage is rapid induction for emergent deliveries. So all we have to do is get her in the OR, get her on the bed in the OR, and anesthesia can put her out in a minute, and then we can deliver this kiddo. Fortunately, most of our deliveries do not require that level of urgency. Our disadvantage is mom can no longer protect her own airway. So in general anesthesia, they are required to have an airway. They're required to have anesthesia there to manage the airway. Physiologic changes of the pregnancy put her at greater risk for aspiration and or injury to her airway. It can cause profound cardiopulmonary suppression in our fetus. Our babies have to be delivered immediately. Our babies can be delivered and be under general anesthesia. That's why we're only going to use this when everybody's there, everybody's ready to go. More than a few minutes, more than about 5 minutes after mom has been given her gases or her meds and she's unconscious, it's going to get to our baby. Hopefully we can have our baby out before our baby is general anesthesia. If not, then we're going to have to provide airway and respirations for our baby once they're delivered. And another disadvantage is mom cannot participate in this delivery. She's unconscious. Typically, if we're talking about an emergency cesarean delivery, family's not allowed in the OR. One, because we're all moving so fast, we don't have time to call them and get them in there, or time to get them dressed appropriately to enter the OR. We don't have the time to help determine where they stand. Are you okay? We are all focused on mom and baby. And then because mom's been unconscious, breastfeeding and skin to skin is often delayed. Please look at your notes. There is a section there that talks about A1, which is Association of Women's Health, OB, and Neonatal Nurses. That's OB Nurses Nursing Professional Organization. They set the standards for what L&D nurses do. And it talks about what the A1 and Texas Board of Nursing position statements say about nurses participating in epidural anesthesia. There are things that nurses can do and things that nurses cannot do. Texas Board of Nursing refers back to the A1 standards and say that for an L&D nurse, they can follow A1 standards. This means only labor and delivery nurses. And if you are on labor and delivery, in order to do these things with an epidural, you have to have competency signed off and in your training record. But if you leave labor and delivery, you are no longer covered by that competency, because Texas Board of Nursing says you cannot do those things once you leave labor and delivery. So you did those things when you were on labor and delivery. Now you're on a med-surg unit, and anesthesia tells you, oh, go in there and remove that epidural catheter. You did that on labor and delivery. You cannot do it now that you're not on labor and delivery anymore. Texas Board of Nursing has a different set of position statements for you now that you're no longer on L&D. Never underestimate labor support for pain relief. Those comfort measures we've talked about. That emotional support and encouragement, position changes and movements. Do you think that's important in labor and delivery? The first part of this lecture, in part 1, I said I want our mantra to be position changes, position changes, position changes. Counter pressure, acupressure. And that's it for this section.